Today we will be talking on treatment of lupus nephritis. So you already know that there are 6 histological classification of lupus nephritis: 1, 2, 3, 4, 5, 6. 6 means it is advanced sclerosing lupus nephritis. Here immunosuppressant don't work, and for class 1, 2 we generally do not give immunosuppressants. 3 is focal lupus nephritis, and this is diffuse lupus nephritis. No? And this 5 means membranous lupus nephropathy. Membranous lupus nephropathy. So when we talk about treatment, we are generally talking about these 3 classes. Okay. So class 3, 4, 5. Okay. Now let's talk about the phases of treatment. So there are 2 phases. One is called initial phase, and another is subsequent phase. So what is the aim of initial phase? Aim of initial phase is to control the current clinical and flare in lab report, like immunological flare, hematological flare, renal flare, like those things. Okay, so control the current clinical and other immunological flare, hematological flare, whatever flare may be. So control the current clinical status. But here the aim is to prevent relapse and maintain the patient in remission. Okay. And what is the duration of treatment in initial phase? Duration is you can go up to 6 months. Okay, like that. If patient is not responding to immunosuppressant up to 6 months, then we can consider resistance to those drugs. We need to think for other drugs like second lines, rituximab, like those things. So initially the duration is up to 6 months, you can say. And for subsequent the phase, the duration is 3 to 5 years. 3 to 5 years. And what are the drugs used in initial phase? So we use prednisone, glucocorticoids 0.5 to 1 mg per kg per day. We can give IV methylprednisone. Methylprednisolone you can give like 500 mg per day for 1 to 3 days, and then we can change to oral steroid, oral glucocorticoids. And in addition to prednisolone, what we give? Cyclophosphamide or mycophenolate. And alternative drugs are also there, like you can give mycophenolate with calcineurin inhibitors like tacrolimus, cyclosporin, voclosporin, or you can give Belimumab with cyclophosphamide. This is inhibitor of B lymphocytes. Okay. So this is regarding initial therapy. And regarding subsequent therapy, what are drugs? We can use prednisolone at low dose, 0.05 to 0.2 mg per kg per day. You can use like maintenance dose like 2.5 mg every alternate day. Okay. Or you can use mycophenolate 1 gram BD, or 500, titrate down to 500 mg BD. Or you can use azathioprine. If patient cannot tolerate mycophenolate, we can use 2 mg per kg per day and limit the dose to less than 200 mg per day. Okay, so this is in short about initial therapy and subsequent therapy. Now let's talk about in detail. Regarding initial therapy, I already told you the prednisolone dose is 0.5 to 1 gram per day you can use. Okay, you generally use 0.5 mg per kg per day. Don't go for 1 mg, because it has been shown that even if you use 0.5 mg per kg per day, it is equally equivalent to using higher dose. So limit prednisolone dose to this. Okay, and in addition to prednisolone, what we use? You use mycophenolate mofetil. Mycophenolate mofetil, initially we start like this, 500 mg BD for first week. Next week you can go for 1 gram BD. Next week you can go for 1.5 gram BD. Okay, so you increase gradually the dose. because it is associated with gastrointestinal side effect like nausea, vomiting, diarrhea. So if patient experiences GI side effects, consider changing to enteric coated mycophenolate sodium, which has less GI side effects. And regarding conversion factor, 1 gram mycophenolate mofetil is equal to 0.72 gram enteric coated mycophenolate sodium. Okay, so you can use mycophenolate, or if patient cannot tolerate mycophenolate, then you can also give cyclophosphamide. And you know that this is available in two formulations, oral formulations and IV formulations. And regarding IV formulation, IV cyclophosphamide, you can give in two ways. Cyclophosphamide you can give in two ways. One, you can give like this. You can give 0.5 to 1 gram per square meter body surface area every month for 6 months. You call for follow-up patient in 2 weeks, and you look for total leukocyte count, absolute neutrophil count. If it is less than 3500, absolute neutrophil count is less than 1500, then what you do? You decrease the dose. Decrease dose by 0.25 mg per square meter. 0.25 gram, it is gram per square meter. But let's suppose it is greater than 3500, it is greater than 1500, then we increase by 0.25 gram per square meter if there is no clinical response. So this is one is according to body surface area and adjusting the dose, and another is fixed dose, fixed IV dose. 500 mg IV cyclophosphamide every 2 weeks, for total of 6 doses. So this is regarding IV cyclophosphamide. And next is oral cyclophosphamide. The dose is 1 to 1.5 mg per kg body weight per day. You continue for 2 to 6 months. So this is regarding oral cyclophosphamide. So you can use prednisone with mycophenolate if patient cannot tolerate mycophenolate, or if there is fertility issue, because you know cyclophosphamide causes gonadal toxicity. So we generally, in young female, we do not generally prefer cyclophosphamide. Then we go for mycophenolate. Okay, but if patient cannot tolerate, then we can consider cyclophosphamide as well. This has both has equal efficacy. Okay, so prednisone with mycophenolate or cyclophosphamide. And what are alternative regimens? Alternative regimens are, you can use Belimumab with cyclophosphamide. We can use mycophenolate with calcineurin inhibitors like cyclosporine, voclosporin, tacrolimus. Okay, tacrolimus. So these are alternative therapies. Generally, this is we use in our practice. So this is regarding initial therapy. And let's talk about subsequent therapy. So what is the dose of prednisone? I told you. Using subsequent therapy, we can use 0.05 to 0.2 mg per kg per day body weight prednisolone. Okay, and we can use mycophenolate as well, like 1 gram BD. We can titrate down to 500 mg BD, like that. Okay, and we can also use azathioprine. 2 mg per kg body weight. Limit the max dose to 200 mg per day. Okay. So when do we use mycophenolate and when do we use azathioprine? This has more relapse compared to mycophenolate, but there are some conditions where we can't use mycophenolate and we have to give azathioprine. Like in pregnancy, if patient is pregnant or planning to begin pregnant, since mycophenolate is teratogenic, we have to switch to azathioprine. Or if patient cannot afford mycophenolate because of cost issue, then we have to consider changing to azathioprine. And you know guys, in gout, when you are using allopurinol, you can't give azathioprine. In that condition, you have to give mycophenolate. Okay, so those are some of the conditions where you have to consider whether we to give mycophenolate or azathioprine. So we have to think in those instances. Okay, so these till now what we discussed regarding immunosuppressants treatment in lupus nephritis, in initial therapy and subsequent therapy. And in addition to immunosuppressants, what we need to give, we need to manage BP control, we need to control for hyperlipidemia with statin, hyperlipidemia, we have to use RAS inhibitors with ACE inhibitors, ARB, RAS inhibitors, advice for sodium protein restriction, and even you have to consider hemodialysis or peritoneal dialysis if it is needed. Oh, okay. Volume refractory fluid overload, which is refractory to diuretics in those conditions, or end-stage kidney disease, uremic features. In those conditions, we also have to consider. So those supportive treatments are already there. We have to take care those as well, because those are equally important in addition to immunosuppressant treatment. And regarding follow-up of patients, in initial therapy, you call for follow-up in every 2 to 4 weeks, and in subsequent phase you call for patient in about 3 months, you can say. And in follow-up you check for whether clinical response or not, whether patient has acquired any infections due to immunosuppressants or not. Okay, so and other parameters, you check anti-DS DNA, you check C3 C4 to check for disease activity, ESR CRP. Okay, you check for urine protein creatinine ratio, you check for urine analysis for sediment, you check for serum creatinine. Okay, so these are the features you look for in follow-up. So till now we discussed there are 2 phases in treatment of lupus nephritis: initial phase and subsequent phase. Initial phase we give prednisolone 0.5 mg per kg per day combined with mycophenolate, or prednisolone combined with cyclophosphamide. And alternate regimens for initial therapies are Belimumab, calcineurin inhibitors. So you can give calcineurin inhibitors combined with mycophenolate, or Belimumab combined with cyclophosphamide. No, so Belimumab combined with cyclophosphamide, calcineurin combined with mycophenolate. These are alternative regimens in initial therapy. And in subsequent therapy, what I told you that you can use azathioprine, you can use mycophenolate, you can use prednisolone low dose 0.05 to 0.2 mg per kg body weight prednisolone you can use. And after initiating immunosuppressants, you also need to consider other supportive treatments like RAS inhibitors, RAS BP control, hyperlipidemia management, sodium and protein restrictions, and need for dialysis. And you call for follow-up visits every 2 to 4 weeks in initial phase, and in subsequent phase every 3 months. Okay, so this is overall about treatment of lupus nephritis. Thank you.